Below is a much more detailed and expanded explanation of X-linked agammaglobulinemia, XLA, suitable for academic assignments, nursing notes, or medical reports. X-linked agammaglobulinemia, XLA, detailed overview. Number 1. Introduction. X-linked agammaglobulinemia, XLA, also known as Bruton's agammaglobulinemia, is one of the earliest known primary immunodeficiency disorders. First described in 1952, XLA is characterized by a profound defect in the development of B lymphocytes, resulting in an absence or severe reduction of all major immunoglobulin classes. The disorder typically becomes clinically apparent in male infants after maternal IgG antibodies wane. Without early diagnosis and proper management, XLA can lead to repeated infections, chronic organ damage, and reduced quality of life. However, with immunoglobulin replacement therapy and vigilant infection control, affected individuals can live long, healthy lives. Number 2. Definition. X-linked agammaglobulinemia, XLA, is defined as a hereditary primary immunodeficiency caused by mutations in the Bruton tyrosine kinase BTK gene, leading to a block in B-cell maturation at the pre-B stage. This results in markedly reduced or absent B lymphocytes, severe deficiency of immunoglobulins, IgG, IgA, IgM, IgE, IgD, impaired antibody-mediated immune response. Therefore, affected individuals are highly susceptible to recurrent bacterial infections, particularly those caused by encapsulated organisms. Etymology. A equals without, gamma globulin equals immunoglobulins, emia, presence in the blood. The condition is named after Dr. Ogden Bruton, a pediatrician who identified the disorder in a young boy with recurrent infections and demonstrated the absence of gamma globulins. Number 4. Epidemiology. Occurs in 1 per 100,000 to 200,000 live births. Affects almost exclusively males due to X-linked inheritance. Female carriers may be asymptomatic or mildly symptomatic due to X chromosome inactivation, lionization. Symptoms typically begin between 6 to 12 months of age, coinciding with the decline of protective maternal IgG. No specific ethnic, racial, or geographic predisposition identified. Number 5. Types. While XLA is a specific genetic disorder, agammaglobulinemia broadly includes A. X-linked agammaglobulinemia XLA, caused by BTK mutation, most common type. B. Autosomal recessive agammaglobulinemia, caused by mutations in genes involved in early B-cell development. IgHM, heavy chain mu gene, IGLL1, lambda 5 gene, CD79A or CD79B AR is rare and presents similarly to XLA. Number 6. Causes. The primary cause of XLA is a mutation in the BTK gene located on the X chromosome XQ21.3 to Q22. BTK is essential for pre-B cell receptor signaling, progression from pro-B to pre-B stage, survival and maturation of B-cell precursors. Mutation, absence of functional BTK, halted B-cell development, no mature B-cells or plasma cells, severe immunoglobulin deficiency. Number 7. Risk factors. Male gender. Family history of X-linked immunodeficiency. Carrier mother with BTK mutation. Genetic susceptibility, BTK mutation clusters. There are no lifestyle or environmental risk factors. Number 8. Complications. Untreated or poorly managed XLA can lead to A. Infectious complications. Recurrent sinusitis, otitis media, bronchitis. Pneumonia, bronchiectasis, meningitis, sepsis, gastrointestinal infections, Giardia, Campylobacter. B. Chronic organ damage, bronchiectasis, chronic lung disease, liver damage from repeated infections. C. Autoimmune conditions due to immune dysregulation, arthritis, dermatomyositis-like syndromes, inflammatory bowel disease. D. Growth and development issues, failure to thrive in early childhood, poor weight gain due to recurrent infections. Number 9. Pathophysiology. Normal B-cell development. Bone marrow stem cell, pro-B, pre-B, immature B, mature B-cell. BTK is required at the pro-B to pre-B stage. In XLA1, BTK mutation, absent BTK protein. 2. Pre-B cells cannot progress. 3. Bone marrow shows arrest at pre-B stage. 4. Absence of mature B cells in peripheral blood and lymphoid tissues. 5. Immunoglobulin production is nearly zero. 6. Impaired humoral immunity, susceptibility to encapsulated bacteria. Encapsulated bacteria particularly dangerous, Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitis. Number 10. Stage 1. Genetic stage. Mutation is present at conception. 2. Asymptomatic stage, 0 to 6 months, maternal IgG protects infant. 3. Symptomatic stage, 6 to 12 months onwards. Recurrent infections begin once maternal IgG wanes. 4. Chronic stage repeated infections cause structural damage, e.g. bronchiectasis. 5. Treated managed stage. With lifelong immunoglobulin therapy, infection frequency dramatically decreases. Number 11. Signs and symptoms. A. Infection-related. Recurrent upper respiratory infections, ear infections, sinus infections, chronic cough, pneumonia, skin abscesses, conjunctivitis, GI infections, diarrhea. B. Physical signs. Absent or underdeveloped tonsils, small or non-palpable lymph nodes, poor growth, normal T-cell levels. C. Laboratory features. Very low IgG, IgA, IgM, absent CD19 plus B cells, absent response to vaccines. Medical diagnosis. Diagnosis involves A. Laboratory tests. Serum immunoglobulin levels markedly reduced, flow cytometry, absence of B cells. CBC normal except during infection, vaccine titers absent or very low. B. Genetic testing. BTK mutation analysis, carrier detection in mothers. C. Imaging. Chest X-ray may show chronic infections or bronchiectasis. CT scan, sinus abnormalities. D. Other tests, bone marrow biopsy rarely needed. Number 13, nursing diagnosis. Risk for infection related to impaired immune function. Ineffective airway clearance related to recurrent respiratory infections. Imbalanced nutrition, less than body requirements. Fatigue related to chronic illness. Anxiety and fear in parents related to child's diagnosis. Knowledge deficit regarding disease management. Number 14, medical management. 1. Immunoglobulin replacement therapy, IVIG, every 3 to 4 weeks, CIG weekly or biweekly. Lifelong therapy restores IgG levels and reduces infection frequency by 80 to 90%. Antibiotics. For acute infections, prophylactic antibiotics in severe cases. 3. Avoidance of live vaccines, MMR, OPV, varicella, BCG. 4. Monitoring, regular lung function tests, immunoglobulin level monitoring, growth and nutritional evaluation. Number 15, nursing management. A. Assessment. Monitor respiratory status, assess for signs of infection, track temperature, sputum, lung sounds. B. Interventions. Ensure timely IVIG, SCIG administration, promote hydration and high-protein diet, maintain strict infection control practices, educate parents on early signs of infection, teach how to administer SCIG at home. C. Family support. Provide psychological support, encourage participation in support groups, prepare family for long-term management. Number 16. Treatment options. Immunoglobulin replacement therapy, gold standard, broad-spectrum antibiotics, chest physiotherapy for lung infections, nutritional support, gene therapy, experimental, ongoing research. Number 17. Psychosocial interventions, 5 detailed. 1. Family counseling. Helps parents accept diagnosis, manage chronic stress, and plan long-term care. 2. Patient and parent education. Includes recognizing infection early, treatment schedules, vaccination guidance. 3. Support groups. Linking families with others who have children with primary immunodeficiency. 4. Stress management programs. Relaxation techniques, anxiety reduction strategies, coping skills. 5. School and social integration support. Ensuring the child can attend school safely, coordinating with teachers. Prevention. Primary prevention. Not possible due to genetic nature of disease. Secondary prevention. Genetic counseling for carriers. Prenatal diagnosis, chorionic villus sampling, amniocentesis. Early screening in infants with family history. Tertiary prevention. Prevent organ damage by treating infections early. Lifelong immunoglobulin replacement. Avoid exposure to infectious environments. Number 19, conclusion. X-linked agammaglobulinemia is a well-understood primary immunodeficiency arising from BTK gene mutations leading to profound humoral immune defects. Early symptoms typically appear after the first few months of life, marked by recurrent bacterial infections. Despite its severity, XLA is highly manageable with immunoglobulin replacement therapy, infection control, and supportive care. Multidisciplinary management, including medical, nursing, and psychosocial support, allows affected individuals to live healthy, productive lives. Continued advancements in genetic therapy provide hope for future curative treatments. Thank you. Have a nice day.